Good evening, everyone, and welcome to our second Wednesday webinar for the SSAT. This was, the webinar series was grown out of our intention to kind of capture at least some of the incredibly valuable scientific material that was selected for presentation for the SSAT program of the DDW. Again, this is our second week doing this. These webinar series will include papers that were selected for our traditional plenary and presidential plenary sessions at the annual meeting. So you're in a very esteemed group in being selected to present, and we are certainly grateful to all of the presenters who have shared their PowerPoint presentations with the discussants. We hope to have a lively and interactive presentation and discussion for each of the papers. Again, we're trying to limit the presentations to under 10 minutes to allow for at least 5 minutes of open table discussion. There has been an assigned discussant for each of the papers. 4 papers will be presented this evening. And the primary discussant will have the ability to address the presentation first, and then we'll open it up to the Q&A session. Now, we will not have interactive audience questions. We will survey the Q&A button, and we'll hope to be able to at least gather at least 1 or 2 questions from the audience at large. So let's not waste any time this evening. Everyone's time is extremely valuable. And Anthony's provided you here with some instructions. And with that, why don't we go ahead and get started? It does seem like this is a little HPB heavy. So 3 of the 4 papers this evening's webinar were from the HPB track, and then 1 from the colorectal small bowel track. So we're a little heavy in HPB, and hopefully this will be a very enjoyable, educational, and valuable webinar series for everyone this evening. And Yoshi, I think we had you selected as the first presentation. So Yoshi Kawaguchi will present from MD Anderson, and Danielle DePeralta, an HPB surgeon and surgical oncologist from Northwell, Long Island, will be your primary discussant. So Yoshi, if you're ready, we're going to have you share your presentation.
Thank you very much for your kind introduction. So I want to share my slides first. Can you see my slides?
Yeah, they look great.
Okay. Good evening, everybody. I'm Yoshi Kawaguchi. Thank you very much, SSAT Organizing Committee and Dr. House for moderating our session. I'm honored to talk about our study. I have a disclosure as in the slide. In patients undergoing resection of colorectal liver metastasis, the following somatic gene alteration were associated with worse survival: RAS, BRAF, TP53, and SMART4. Our recent study showed that these 4 genes were risk factors for overall survival in patients undergoing resection of colorectal liver metastasis. A previous study showed that FBX77 alteration was associated with worse survival in patients with unresectable metastatic colorectal cancer. The overall survival was significantly different between wild type and alteration of this gene. The aim of our study is to evaluate the impact of FBX77 alteration on survival after resection of colorectal liver metastasis. We studied 476 patients who underwent resection of colorectal liver metastasis, selected by the criteria in this slide. Demographics of 476 patients. The median age was 55 years old. 87% of patients had primary T category more than 3. 70% of patients had primary lymph node metastasis. 90% of patients underwent prehepatectomy chemotherapy. Our cohort had complete data of somatic gene alteration from the 50 gene panel. This slide shows the frequency of somatic gene alteration. FBX77 was altered in 6% of patients undergoing resection of colorectal liver metastasis. TP53, APC, RAS, PIK3CA, SMART4 were altered in more than 10% of patients undergoing resection of colorectal liver metastasis. BRAF is a known prognostic factor. We analyzed these somatic genes in a Cox model with 11 clinical pathologic factors. This is a Cox model for overall survival. BRAF, RAS, TP53, SMART4, and FBX77 were all independent risk factors for overall survival in patients undergoing resection of colorectal liver metastasis, together with prehepatectomy chemotherapy, number of colorectal liver metastasis, largest diameter of colorectal liver metastasis. This is a Kaplan-Meier curve of overall survival. The 5-year overall survival in patients with FBX77 alteration was 30%. The 5-year overall survival in patients with wild type was 61%. The difference was significant. This is a survival curve using covariate adjusted overall survival method. The difference remains significant after adjustment of other risk factors. The 5-year overall survival with this alteration was 40%, and the 5-year overall survival with wild type was 59%. FBX77 belongs to Notch signaling pathway. Notch signaling pathways control cell growth. FBX77 works as an inhibitor in this signaling pathway. If FBX77 is altered in this signaling pathway becomes uncontrollable. We previously reported the prognostic importance of 3 cancer-related signaling pathways: MAP kinase pathway, P53 pathway, TGF-beta pathway, for patients undergoing resection of colorectal liver metastasis. Our current study showed that in addition to these signaling pathways, FBX77 and the Notch signaling pathway may have deleterious effect on survival in patients undergoing resection of colorectal liver metastasis. In conclusion, FBX77 is the 6th common alterations in patients with colorectal liver metastasis, belongs to Notch signaling pathway, associated with worse survival. Information regarding combination of gene alteration may contribute to risk stratification and treatment decisions. Thank you very much for your kind attention.
That's very nice, Yoshi. And we're going to go ahead and have Dr. DePeralta discuss this very nice paper. Well done, Yoshi.
Thank you so much.
Hi, everyone. Thank you very much for having me, Danielle DePeralta from Northwell Health. Dr. Kawaguchi, thank you for sharing this extremely important work and for such a clear presentation. I think there's really no question that the work from Dr. Bote and from your group has really revolutionized the way that surgeons think about colorectal liver metastases. And it's really forced us to think beyond the typical clinical and pathologic factors and really have a much more sophisticated understanding of these tumors at the molecular level. As a new attending, I think the thing that I struggle with the most when it comes to utilizing these data is how to incorporate them into my clinical practice. So I'm always very careful to ask about KRAS status when we're discussing patients at tumor board, and there's no doubt that I use the molecular information for its prognostic value when I counsel patients in the office. However, the mutational analysis as of yet does not really change my management when I'm evaluating a new patient for potential resection for colorectal liver metastases. So my question for you, Dr. Kawaguchi, is should it change my management? And if so, how should it change it?
Thank you very much for your very important question. In our clinical practice, we think this information may change surveillance intensity. For example, if the patient had a bad mutation, if the patient had 3 mutations, RAS, TP53, and SMART4, and also FBX77, these patients have the higher risk of recurrence. So we should see these patient group more frequently than the others. So that is one thing. And another changing factor is maybe we can stratify these patients by mutation status, and we can decide who should have chemotherapy after surgery or not, because the clear evidence, we do not have the clear evidence for adjuvant chemotherapy after resection of colorectal liver metastasis. And lastly, we are thinking we can use this information to decide whether to perform aggressive re-resection or aggressive treatment after recurrence in these patients. Because if the patient has all wild type mutation status, these patients have a good prognosis. So we may decide to have an aggressive treatment option for this good patient group. That is what we are thinking to change our clinical practice based on this mutation data.
Thank you very much.
Great, Yoshi. I have a question for you. These are fantastic data. And again, your work with Dr. Vote continues to transform how we manage patients with colorectal metastases. I was curious, though, in looking at your Kaplan-Meier curves and your log-rank analysis, that this particular marker seems to discriminate patients in more of a late relapsing scenario. So you see the major separation of your overall survival curves really didn't start to deflect until about 18 months, even 2 years. So I think it's rather unique. This particular marker may be able to discriminate patients who are at risk for late relapse, not so much for early relapse, which a lot of your work done before. Do you agree with that statement? And do you have anything else to add about this ability of this particular marker to discriminate late relapsers?
Yeah, thank you very much for your another important question and another important comment. We recently published about the data, and patients with RAS mutation had also risk factor even in patients without recurrence after 2 years. So that is exactly what you pointed out. We did not check about this phenomena in FBX77, but we published about this fact in patients with RAS mutation. So biological factor is more important to know the patients who have late recurrence. That is what we are believing.
Great. Thank you so much, Yoshi, and very beautiful work and an excellent presentation. And Danielle, thank you for very insightful questions and for stimulating a nice paper discussion. We're going to move on to our second presentation. Anthony, if you could just put up your slide here.
And everybody see this?
Yeah. So Michael, great. Yeah. So Michael Poulson from Boston, from BU, is going to be presenting residential segregation, structural racism, and how it relates to colorectal cancer outcomes. So Michael, your slides look great, and you may begin whenever you're ready.
Great. Thank you for that introduction, Dr. House, and thank you all for coming. I'm happy to present our work on behalf of our co-authors, and obviously with recent events, this is very timely given the national discussion on structural racism. I have nothing to disclose. As far as background, there are well-documented racial disparities in colorectal cancer. Black patients see a 20% higher incidence as compared to white, and Black patients are less likely to undergo surgical resection while having lower overall survival. There have been many proposed reasons in the literature around this, specifically tumor characteristics and genetics, as well as socioeconomic status, comorbidities, and insurance coverage. But little has been looked into the built environment, particularly around segregation. And segregation has a very long history that dates back to emancipation. But redlining and racist housing policies in the 1930s served to segregate Black Americans into urban centers of cities. To date, about 75% of these hazardous or redline neighborhoods are low to middle income, and 65% are primarily minority neighborhoods. Studies have shown the impact of segregation in hypertension, cardiovascular mortality, and cancer mortality, particularly in breast cancer, prostate cancer, and lung cancer. So the purpose of our study was to understand the effects of structural racism in the form of residential segregation on Black-white colorectal cancer disparities. So patient-specific data was obtained from all patients with colon and rectal cancer from the SEER database between 2005 and 2015. The SEER database provides county residents of patients included in the database, which allows one to compare to census data. We obtained county-specific demographic, income, education, housing, and insurance information from the 2010 decennial census and the 2013 5-year estimates of the American Community Survey. The sample was then limited to Black and white patients living in the 100 most populous participating counties in SEER. Our exposure of interest was the index of dissimilarity, which is a validated measure of segregation. And this measures the geographic evenness of distribution of two groups. And here we looked at Black and white individuals. It was calculated from census blocks within each county to give a surrogate measure of segregation. And 0 denotes no segregation, while 1 denotes complete segregation. And this represents the proportion of people within an area that would need to move to achieve complete integration. Our outcomes of interest were advanced stage of diagnosis, which we termed stage 4, surgery for localized resectable disease, which we called stage 1 and 2, and then cancer-specific 5-year survival. For the outcomes advanced stage of diagnosis and surgery for resectable disease, we performed a Poulson regression with robust error variance, controlling for age of diagnosis, sex, and comorbidities. As far as cancer-specific mortality, we looked at relative hazards of death, controlling for age of diagnosis, sex, region, and stage. In our conceptual framework, socioeconomic, demographic, and insurance variables are likely mediators in the process between segregation and the outcomes of interest, and thus were not controlled for in the model. For each of the previously mentioned models, we performed a combined regression analysis and a stratified analysis. With the combined regression analysis, we incorporated race into the model, which allowed us to obtain predictions for each level of index of dissimilarity. And this allowed us to compare Black and white disparities across varying levels of segregation. We then did a stratified analysis by race for both Black and white patients, and this assessed the impact of segregation for Black and white patients alone. And these are the baseline characteristics of the patients included in the study. As you can see, Black patients were generally in the South and West. A higher percentage presented at stage 4, and a lower percentage underwent surgery overall. And here you can see the stepwise model for advanced stage of diagnosis, again, controlling for age of diagnosis, sex, and region. In the final model, here, model 4 on the right, you can see that Black patients are 19% more likely than white to present at advanced stage. The graph here depicts the predicted proportion of people who presented at advanced stage by race from the final model discussed in the previous slide. And as you can see, despite the level of segregation, there are continued disparities between Black and white individuals across all levels of segregation. And then here on the right, we report the stratified relative risk ratios of presenting at advanced stage with increasing segregation. And Black patients were 41% more likely to present at advanced stage with increases in segregation. And similarly, white patients saw a 17% increased risk of presenting at advanced stage with that same increase in segregation. And here you can see the stepwise model for surgery for resectable disease. And again, we controlled for age of diagnosis, sex, and region. And in the final model, you can see that Black patients are 2% less likely than white to undergo surgical resection. And here you can see the graph that depicts the predicted proportion of people undergoing surgery in Black and white individuals across all levels of segregation. And you can see at low levels of segregation, there are no differences between Black and white, indicating that there is no disparity between the two. Here on the right, we report the stratified relative risk ratios. And as you can see, Black patients are 5% less likely to undergo surgical resection with increasing segregation, while white patients are 5% more likely to undergo surgical resection with that same increase. However, these numbers are small and likely not clinically relevant. And finally, here we present the stepwise proportional hazards model for cancer-specific 5-year survival. And in the final model, you can see that Black patients have a 26% increased hazard of death when compared to white. And the graph here depicts the predicted relative hazards of death by race based on the final model from the previous slide. And as you can see, despite the level of segregation, disparities persist between Black and white individuals across all levels of segregation. And then on the right here, we report the stratified hazard ratios of cancer-specific mortality. And as you can see, Black patients had a 43% increased hazard of death with increasing segregation, while there was no significant change in hazards for white patients. So overall, both Black and white patients are more likely to present at advanced stage with increasing segregation. Black patients were less likely to get surgery with increasing segregation, while white patients were more likely. And Black patients saw worse cancer-specific survival with increasing segregation, while white patients saw no difference. And despite the small differences between Black and white patients in terms of surgical resection, these disparities can potentially be eliminated at low levels of segregation. But despite improvements in advanced stage of diagnosis and cancer-specific survival among Black Americans at lower levels of segregation, the disparities between Black and white individuals across all levels of segregation persisted. So our findings here really challenge the notion that genetics alone contribute to the disparities we see in colorectal cancer. Black race, as we described it in research and medicine, is a social construct that encompasses a vast array of genetic ancestries. However, this socially constructed group has been subject to a long history of structural racism with huge socioeconomic impacts and resulting health effects today. This history of structural racism in the form of residential segregation and the historical loss of equity around redlining affects our patients today. These segregation effects have significant impacts on the built environment in which Black Americans live and leads to significant intergenerational poverty. And these effects are likely what drive the outcomes that we see. Really, these findings should drive urban policy reforms to address systemic racism, segregation, and the changes in the built environment that have resulted from this history. And we can show that these will improve colorectal cancer outcomes. Thank you very much. I will now take any questions, and thank you to Dr. Kwan for joining us.
Great. Very nicely presented, beautiful data. Dr. Mary Kwan is going to discuss your elegant paper.
Yeah, thank you so much for inviting me to present on this study. This is a SEER study where the authors merged the SEER database with census data. That's not an insignificant task, and you should be congratulated on that. It adds to a body of literature in colorectal cancer disparities using this relatively newly studied variable of segregation. You know, my big picture question here is for more of your thoughts on how surgeons should use this study. You know, obviously this is a major message for how pernicious the effects of segregation are on healthcare outcomes and cancer outcomes specifically. But it's a bit of a vague target for intervention. You know, we can approach socioeconomic disparities with insurance reforms or programs such as federally qualified health centers for interventions. We can approach health literacy issues with educational programs, public health campaigns, and even approach trust issues in these Black communities with community-based interventions. But segregation, I think, is quite a challenging societal problem. And as you mentioned in the introduction, you didn't control for socioeconomic and insurance variables, likely because of the confounding effects of those variables. So I guess the question, other than to highlight a significant structural racism element here, are there any action items? And then more specifically, I have some more specific questions. It appears that the index of dissimilarity is assigned to each patient within your data set, and then that's assigned based on the county from which the patient's from. Your study focuses on 100 of the most populous counties within SEER. I guess my question is what you think of as an appropriate index of dissimilarity. Give us some background on where that number should be in ideal situation. And then I also see that you controlled in your analysis for the region of the United States, and within the multivariable analysis, region was significantly associated with all of your outcomes. Would you be able to share which region of the 4 regions had worse outcomes? Is it similar that one region is a culprit for all of your outcomes? And of course, I imagine segregation varies from state to state depending on and region to region. I just don't know whether it's necessary to control for region. If anything, I think it detracts from your evaluation of segregation. It wouldn't be an excuse that there's more segregation, for example, in the South, and that's why maybe the outcomes are stratified on that variable. So if you have any comments on that, overall, congratulations on a really well done study.
Thank you very much, Dr. Kwan. So to start with what surgeons can do, I think from an overall standpoint, we see a lot of the effects of these societal problems, and physicians can act as advocates to bring this to light to policymakers. And I think this paper starts with that, but it takes people on the ground who see these patients and understand their stories to really highlight that. But I think even on top of this, what was most worrying about this study is that despite lower levels of segregation, which would presumably come with better insurance access and better access to healthcare, we still see disparities between Black and white individuals. And this hasn't been studied, but I think we need to really understand if this is something inherent in healthcare, that maybe there's some bias that continues despite levels of segregation. I think this is something that surgeons can really think about, even though we didn't directly address this in the study. As far as the index of dissimilarity, it does vary widely. So interestingly, the Midwest is actually one of the most segregated areas. The South actually is probably middle of the road. And this kind of comes from the Great Migration during Reconstruction after the Emancipation Proclamation. And people tended to move to the north, to cities like Detroit and Chicago. And interestingly, this was the region, the Midwest, that had the worst outcomes. The range, so generally in a city like Detroit, which has very high levels of segregation, the index of dissimilarity would be about 0.85. Don't quote me on that exact number, but it's generally around there. Generally, a low level of segregation would be 0.2 to 0.3. You may see that actually in the West, in a lot of Californian cities, where there actually is, believe it or not, less segregation than the Midwest. Hopefully I addressed all those questions, but I'm happy to hear more.
Thanks, Dr. Kwan, for stimulating a very important discussion. Michael, this couldn't be more timely with the sad and disturbing events that have occurred over the past 2 weeks. And the fact that you were able to compile and analyze these data so scholarly and scientifically, this is an incredible credit to you and your group. And we hope that you continue to bring such studies to the SSAT program as part of the DDW each year. We do have a question from one of your neighbors in Boston, Dr. Z. Fong. Would like to ask you, when you looked at all of the factors, here you focused on kind of race and the segregation component, but how about other socioeconomic factors, education level, income, how does that discriminate groups either based on race or not in terms of their short and long-term outcomes with colorectal cancer?
Sure, and it's been shown that socioeconomic status as a whole has a detrimental impact on Black Americans, and this has been shown in other studies. We do plan to account for these different variables in a mediation analysis, hopefully sometime in the future, to measure the mediating effects of socioeconomic status, education. I mean, there's so many things that come with segregation that it's hard to measure all of them, but generally leads to poor education, poor access to healthcare, significant poverty, high incarceration rates, high numbers of single-family households. So it's difficult to factor in all of these that likely contribute in their own way, but in our conceptual framework for this study, we see them as mediators from segregation to the outcomes of interest.
Well, I sure hope, Michael, that you and your group have decided to submit this paper to the Journal of Gastrointestinal Surgery. This will be highly cited, and it couldn't be more appropriate. A message from SSAT President Mark Callery. Wanted to congratulate you on a wonderful presentation, and he also wanted to, for all the panelists as well as the participants on this evening's webinar, that the SSAT will be publishing a statement probably within the next 48 hours denouncing all racism with healthcare delivery from our Diversity and Inclusion Liaison Committee. And so, Michael, thank you once again for a wonderful presentation.
Thank you.
We'll now move on to our third presentation. And this will be titled Hepatic Steatosis After Neoadjuvant Chemotherapy for Pancreatic Cancer, the Incidence of this Disease and Implications for Outcomes After Pancreatoduodenectomy. This will be presented by Dr. Mohammed Al-Tamimi, HPB Fellow at Indiana University, and the primary invited discussant is Dr. Mark Talamonte.
Dr. House, are you able to see my screen?
Yeah, we will shortly here, Mo. About 15-second lag here, Mohammed.
Do you see it now?
We see you. Have you shared your screen?
Yes, I did. Is it coming up?
We see you. We don't see your slides yet.
Okay, let me just go back to the Zoom and try to share again.
You share your screen, there'll be several options there. You can share your desktop.
Yep. Share screen.
Okay, just go into presentation mode, Mohammed.
Okay. Thank you for the opportunity to present. Also, thanks to the SSAT for giving me this opportunity, to Dr. House for being a great mentor on this project. I'm the HPB Fellow at Indiana University. So our presentation, as Dr. House mentioned, is hepatic steatosis after neoadjuvant chemotherapy for pancreatic cancer, identifying the incidence and implications for outcomes after pancreatoduodenectomy. We have nothing to disclose. Pancreatic adenocarcinoma is the third cause of cancer-related death in the United States. Neoadjuvant chemotherapy is increasingly used in clinical practice for pancreatic ductal adenocarcinoma. It's established for borderline and locally advanced disease, and more recently increasing use for resectable disease. However, neoadjuvant chemotherapy can be associated with hepatic steatosis. There are many studies that have looked at the safety of neoadjuvant chemotherapy for pancreatic adenocarcinoma. However, the direct and indirect effects of neoadjuvant chemotherapy on pancreatectomy-specific outcomes require further investigation, specifically within this context of hepatic steatosis, which may result in liver injury and lead to worse surgical outcomes after pancreatoduodenectomy. So the purpose of this study is to identify the incidence of hepatic steatosis after neoadjuvant chemotherapy and determine its impact on early postoperative outcomes after this procedure. This is a retrospective study of prospectively collected database in which we match the Indiana University database for pancreatoduodenectomy to the NSQIP database in the period of 2013 to 2018. Patients undergoing neoadjuvant chemotherapy followed by the Whipple procedure were identified and included in the study for a total number of 139 patients. Those who underwent upfront surgery, 297, or do not have an available image, as well as those who have moderate to severe hepatic steatosis before chemotherapy were excluded from the analysis. The data collected include the standard NSQIP variables, including the targeted NSQIP data, as well as chemotherapy details, such as the regimen, duration, interval from the last chemotherapy to surgery, as well as the radiological data for hepatic steatosis, and spleen size as a surrogate for portal hypertension. The main outcomes were 30-day major morbidity and mortality as standardized by the NSQIP variables. In regard to radiological evaluation of hepatic steatosis, a single radiologist at our institution looked at the CT scans before and after the neoadjuvant chemotherapy. Hepatic steatosis was defined by the relative hypoattenuation of the liver parenchyma density compared to the spleen. As you see on the image to the right, on a non-contrast CT, liver attenuation that's more than 10 Hounsfield units, less than that of the spleen. As you see in this image, it is on the spleen is 40, so it's more intense than that of the liver, suggesting that the liver has hepatic steatosis in this case. In contrast, enhanced CT, liver attenuation would be defined more than or equal 20 Hounsfield units less than that of the spleen. In regard to the grading of hepatic steatosis, moderate and severe were graded qualitatively, and severe steatosis, as an example, is defined as uniform marked hypodensity of the liver in comparison to the spleen. Then the spleen measurement were taken the craniocaudal axis on coronal reformats of the CT scans. In regard to statistical analysis, mainly we use bivariate analysis to define the association between hepatic steatosis and the preoperative variables, intraoperative, as well as the outcomes. And multivariate logistic regression models were used to adjust for confounders in determining the relationship between hepatic steatosis and morbidity or mortality. This is a graph that looks at the comparison of preoperative factors between those two groups with and without steatosis. And just to refer that hepatic steatosis in this cohort was at a rate of 26% out of those 139 subjects who had neoadjuvant chemotherapy. Patients with hepatic steatosis were younger than 70, more likely to be younger than 70, female who had a BMI more than 30. They were less likely to be diabetic, and they were more likely to have had a FOLFIRINOX chemotherapy regimen. FOLFIRINOX was the most common chemotherapy regimen in our cohort. However, in comparison between the two groups, those with the steatosis were more likely to have FOLFIRINOX in comparison to the other regimens such as gemcitabine, paclitaxel. In addition to the other perioperative factors that could affect the outcome, the duration of chemotherapy, those with hepatic steatosis, and these values were mainly for median with interquartile range in parentheses. So those with hepatic steatosis had a median of 75 days of chemotherapy versus 59 days in those without. Platelet count and spleen size, as I said, as surrogates for portal hypertension were not different between the two groups. So is the change in spleen size before and after the chemotherapy. And finally, the time between the end of chemotherapy to OR was also comparable at about a median of 39 or 40 days between the two groups. In regard to comparison of other perioperative factors that could affect the main outcomes, such as the morbidity and mortality, biliary endostent was done in the majority of those cases, and it was not different. Preoperative radiation, 25% in the hepatic steatosis group versus 14%. However, all those variables did not reach statistical significance. Pancreatic duct size, that's more than 3 millimeter. Gland texture, pancreatic duct reconstruction in a form of duct and mucosa anastomosis were all comparable, and so is the vascular resection and reconstruction at 36% versus 24%. When we look at the postoperative outcomes, 30-day mortality was higher in the hepatic steatosis. However, that did not reach a statistical significance. It's about 8% in those with hepatic steatosis versus 2%. And that was not different whether we looked at 30-day mortality or 90-day mortality. Major morbidity, 15% in patients without hepatic steatosis versus 11% in patients with hepatic steatosis, and not different. So is pancreatic fistula, delayed gastric emptying, percutaneous drain placement were not different. And final transfusion requirement were not statistically different between the two groups. In regard to return to the OR, discharge to other than to home, and 30-day readmission were also comparable between the two groups. However, return to the OR was not a very common event. That's why it's not statistically significant, but it's worth mentioning that it's 3% in the hepatic steatosis group versus none in the other group. And hospital length of stay was shorter in the hepatic steatosis group with a mean of 6.6 days versus 8.2 days. In regard to multivariate analysis that adjusted for other confounders in this study, hepatic steatosis had higher risk of mortality. However, the p-value was 0.09, so that did not reach statistical significance. Age more than 70, the duration of surgery, the operative time, and disseminated cancer were independent predictors of or factors that are associated with mortality. And finally, in regard to morbidity, major morbidity, hepatic steatosis was also not associated with major morbidity. So in conclusion, there's limited research that had explored the impact of neoadjuvant chemotherapy-associated hepatic steatosis on the postoperative outcome of the Whipple procedure. And in this series, we demonstrate that hepatic steatosis developed in 26% of patients who received neoadjuvant chemotherapy. Those who are obese, females undergoing longer duration of FOLFIRINOX-based neoadjuvant chemotherapy were more likely to develop hepatic steatosis. And the final take-home message is that hepatic steatosis does not appear to be associated with increased short-term morbidity or mortality after the Whipple procedure. These are some of the references that I used for this presentation. Thank you all, and like to answer questions.
Very nicely done, Mohammed. Dr. Mark Talamonte has agreed and was invited to present your paper. Mark, I think you're live.
Congratulations, Dr. Al-Tamimi. Very nice presentation, and I thank you all for the opportunity to review this well-crafted series of patients undergoing neoadjuvant chemotherapy prior to pancreatectomy. While benefits and overall survival remain elusive, improved rates of nodal negativity, clear resection margins, and disease-free survival substantiate the neoadjuvant approach as a viable and increasingly preferable treatment strategy. The authors acknowledge the limited number of patients and use of a radiographic interpretation to diagnose histologic pathology. They demonstrated no significant increase in major complications or mortality in resected patients with hepatic steatosis after neoadjuvant chemotherapy. I have 3 questions for you, Dr. Al-Tamimi. These highly selected patients made it through chemotherapy and underwent surgery. Do you know how many patients started FOLFIRINOX but developed liver toxicity and required a switch to gemcitabine and Abraxane, or never completed neoadjuvant chemotherapy, or at worst, never made it to the operating room? Can we learn something about preoperative liver-related complications and not just postoperative surgical complications by studying all patients in your database with an intention to treat analysis? Secondly, you evaluated NSQIP and pancreatectomy-specific complications as defined by the ISGPS, but the International Group for Liver Surgery that has defined complications related to neoadjuvant chemotherapy for liver resections, including postoperative jaundice, ascites, renal dysfunction, coagulopathy, malnutrition, and infection. Our institution utilizes FOLFIRINOX extensively, and I have seen each of these problems in patients after pancreatic surgery. Do you have information on these specific complications in your patients? And finally, despite not showing any increase in complications with hepatic steatosis, risk factors for this included obesity and females undergoing prolonged neoadjuvant chemotherapy with FOLFIRINOX. With this knowledge and not yet understanding the long-term sequelae of hepatic steatosis, would you now recommend gemcitabine-based therapy for those particular patients? Again, a very nice presentation. I think it's an important contribution to the literature, and I'm certain it will be cited in the future. Thank you.
Thank you, Dr. Talamonte, for discussing this paper and bringing all these great questions about it. In regard to the first question and whether we can analyze the data in an intention to treat basis, and whether we included or we have information about the patients who did not finish the chemotherapy or whether they switched chemotherapy regimen, we included patients who have had pancreatectomy. So patients who were not or didn't make it to the surgery, those were definitely not included. Probably it's feasible to go back and look at our database to include those, and I think that would be helpful. In regard to switching, I don't have the exact numbers of how many patients to switch from one regimen to the other, but we included all patients who have had started FOLFIRINOX. Very few of them, or I mean, I don't have an objective data to tell you like how many of them did not finish the whole course, but when you look at the total numbers and the median of those, that would reflect which patient who have completed or did not complete. So those who had the chemotherapy for longer duration, obviously those who have patients who were able to finish the whole course of chemotherapy. The other group that did not have the steatosis, they have higher frequency of patients who were not able to undergo the whole course of chemotherapy. So I don't have a specific number for what is the percentage of patients did not finish, because any patient who had, even if it was a single cycle of chemotherapy, was included. So it is more reflected in the duration rather than completing the whole treatment as planned. But I think that's a very helpful information to look at the duration in terms of finishing the whole duration of chemotherapy that's designed versus non. And what is the impact of that on our outcomes. In regard to chemotherapy specific information and data, that's not available from this QIP, although some of the complications in this QIP would reflect some of those variables that you have mentioned, but definitely not all of them, and that would be a limitation to the study. And finally, in regard to changing the regimen of using FOLFIRINOX to another regimen of chemotherapy, probably that would need further discussion in terms of whether there's a switch and how much, if those patients are not or developing hepatic steatosis. Actually, we did not show that they have higher morbidity in our cohort, even though patients who are younger, had the FOLFIRINOX for longer duration, were more likely to have hepatic steatosis. I think we need a bigger study that validates our finding that this affects the morbidity and mortality before we come to the next question of whether we should shy away from FOLFIRINOX in favor of another chemotherapy that has less incidence of hepatic steatosis.
Thank you, Mark. Always incredibly insightful questions. I think this was a very practical complication of neoadjuvant chemotherapy, particularly patients receiving 6 cycles of FOLFIRINOX. That's why we wanted to investigate this to see if this did have negative consequences on the subsequent pancreatectomy. Mohammed, I have one question from Dr. Calorie, our SSAT president. Another, again, very practical question. His concern was, did steatosis was associated with hepatomegaly in your series? And if so, would you ever alter your incision that you typically would use to achieve a pancreatoduodenectomy? And he's curious to know what's used at Indiana University with regards to what's the most commonly performed surgical site incision for achieving a Whipple.
Yeah, very thoughtful question. We didn't look specifically at the size of the liver in determining hepatic steatosis, but as far as our practice at Indiana University, we always do the Whipples through an upper midline incision. In regard to adjustment of the size of the incision, I mean that you would do an incision that will allow you to do a safe operation. The length of the incision. In regard to having a different form of incision, I mean, I haven't had a case where we had to make a different type of incision. So it's mostly an upper midline.
and we'll leave the minimally invasive question, which would follow that brief interaction and discussion. We'll leave that for another time in another forum. Again, thanks, Mark, again, for agreeing to participate as a discussant. Great to see you. And well done, Mohammed. We're going to move on to our fourth and final paper for this Wednesday's webinar. And Dr. Vega on, and you'll be discussing the impact of chemotherapy on pancreatic cancer by stage.
Yes, can you see my screen now?
Yes, we can. Your slides look great, Eduardo.
Thanks, appreciate it. So good evening, everyone. I would like to present the impact of chemotherapy sequencing on pancreatic cancer by stage. The presentation is divided by background, objective, patient and method, result, summary, and conclusion. The possible permutation of chemotherapy to surgery for pancreatic cancer are total neoadjuvant treatment, perioperative treatment, meaning pre- and postoperative chemotherapy, and adjuvant chemotherapy. However, no superiority of a sequence has been demonstrated. Further, no direct comparison by stage have done, and it's still unclear whether there is any benefit of chemotherapy for very early stage of pancreatic cancer. Therefore, the objective of the study is to quantify and compare the benefit by each sequence. To further understand the benefit is dependent on stage, and to see any value for very early stage pancreatic cancer receiving chemotherapy. For that reason, we went to the NCDB data. We looked for pancreatic ductal adenocarcinoma from 2004 to 2016. We select from those patients who were undergoing resection for pancreatoduodenectomy. And then we exclude patients with missing information. And the final cohort was about 23,000 patients. We have to make our own program, custom computer script, to convert AGCC 7 edition to AGCC 8 edition. We use Kaplan-Meier analysis and Cox multivariate regression to look for effect of sequence stratified by stage and factor affecting survival. So our result, as you can see here, this is a multivariate analysis for disease-specific survival. You can take a look of the table. You see the typical risk factor for pancreatic cancer, like grade, size, end disease, T stage, positive margin. But indeed, we want to focus in treatment sequencing. And as you can see here, compared to patients who did not receive chemotherapy, every treatment sequence show significant difference to the surgery alone group. Even more, in this Kaplan-Meier analysis, in the left side, you see in the disease-specific survival, and in the right side, you see the graphic with overall survival. The patients who did not receive chemotherapy are identified by a solid blue line, as you can see in this graphic. There is significantly poor survival compared to any treatment of chemotherapy for both groups. You see postoperative chemotherapy in the green solid line, preoperative chemotherapy in the red solid line, and pre- and postoperative chemotherapy in the orange line, we can identify from those graphics that the perioperative chemotherapy is a trend of better survival compared to those other treatment sequences. In this forest plot graphic that show the risk reduction of disease-specific survival, as a reference, we use the non-chemotherapy group. As you can see, the list of stage in the left side here, and every stage we stratify by the treatment sequence. As you may notice, for every stage, there is significant benefit for patients who receive chemotherapy. Even more, we see an incremental increase of benefit from stage 1A to stage 3, up to have in the perioperative group a risk reduction of 51.5%. In summary, there is a strong positive correlation between a stage and benefit from chemotherapy. We can say that even very early stage of pancreatic cancer benefit from chemotherapy. Although I did not show you this result in the results section, I would like to highlight here that at least almost 30% of patients with pancreatic ductal adenocarcinoma did not receive chemotherapy. Finally, in conclusion, we can say that all resectable pancreatic cancer patients benefit from chemotherapy. There is a trend for optimal survival in the perioperative group. We say that the higher the stage, the greater the benefit. And the message at the end of the study would be that patients who had pancreatic cancer should receive chemotherapy. Thanks.
Outstanding job, Dr. Vega. You and your group with Dr. Conrad's mentorship have done an excellent job analyzing the NCDB for patients with pancreatic cancer who ultimately undergo resection. We want to stay on time, respect everyone's evening hours. So I'm going to limit my discussion to just two questions for you, Eduardo. The first was that the major benefits of neoadjuvant chemotherapy seem to be most apparent for patients with more advanced stages of cancer. So that other than selecting patients who carry chemo-responsive tumors, what do you feel really are the objective benefits of neoadjuvant chemotherapy? Because as we know, most patients who receive at least 3 months of chemotherapy are unlikely to develop detectable metastases that would select them out for resection. And the second question I have for you to address this evening is that the frequency of neoadjuvant chemotherapy, whether it was delivered as perioperative chemotherapy or as total neoadjuvant approach, was quite low and disappointingly low in this modern survey of the NCDB. So do you feel that your data support the benefits of neoadjuvant chemotherapy? Or as you pointed out pretty much in your last conclusion slide, that really the benefits are for systemic therapy regardless of timing? Again, congratulations on a very nice presentation and a very nice contribution to the surgical literature.
Thank you, Dr. House. Regarding the first question about whether there is any major benefit of neoadjuvant chemotherapy, we show in this study that chemotherapy is beneficial for patients with pancreatic cancer. We saw that even in early stage of pancreatic cancer, you get some benefit, although not as much as in stage 3. We think that the benefit those patients receive is enough to optimize his treatment with chemotherapy. We think that chemotherapy should be guaranteed to every one of the pancreatic cancer patients. And that's the reason why we should give chemotherapy to all of those patients, because in any of those treatment sequences, we got benefit either from adjuvant treatment or neoadjuvant treatment. However, we know by data from adjuvant treatment trial that it's very difficult to give chemotherapy in patients with Whipple procedure. So if we can guarantee the chemotherapy, better to do it in a neoadjuvant setting. Regarding whether there is enough data to support that neoadjuvant treatment should be the only conclusion here, I would say our study is very clear. We can say that chemotherapy worked for pancreatic cancer. We did not find any significant difference between treatment sequencing. But because we know that adjuvant treatment is probably received by patients who had pancreatoduodenectomy, we will have to look back to the first question, that it will benefit to guarantees to those patients receive some part of the chemotherapy, at least.
Well done. One last question from our audience. Dr. Zifong has a question for you, Eduardo. And his question is really, he would like to know the proportion of patients who did not manage to receive an operation due to systemic toxicity in each group. Now, this is an NCDB retrospective review, so obviously you can't really address an intention to treat.
So, yes.
But I think all of us would appreciate kind of your insight of what do you feel the dropout rates were? Not so much for patients who received chemotherapy and developed detectable metastases. We know that's incredibly uncommon. It's really what was the dropout rate due to toxicity, so that basically they weren't a candidate for operation because they suffered side effects and extreme major toxicity from the neoadjuvant approach.
So first of all, as you pointed out, this is NCDB data. And one of the greatest limitations to talk about this topic is the intention to treat analysis. That probably will answer the question of Dr. that who asked me this. But my feeling is very low from our practice. Patients who did not receive any chemotherapy because of toxicity is very low. And indeed, very depending on the medic oncologist you have working with him. And that's the reason why in the NCDB data, we can extrapolate that from other studies that we have analyzed about delay of adjuvant treatment, that most of the risk factors are related to patients with in a low volume center or in a community center who they're not probably feel comfortable treating the toxicity. We know that the art of the MEDONC probably is treat the toxicity of the chemotherapy they give. So my feeling is very low, although we cannot answer by intention to treat analysis by NCDB.
Again, great job, Eduardo. I'd like to thank everyone who was on this evening's webinar. This was 4 fantastic presentations, very lively discussions, and I would like to thank everyone for taking an hour out of your evening to continue to support the ideals and the mission of the SSAT and its annual program. I'd like to wish everyone a good evening, a good night, and continue to take care of yourselves and your neighbors. Be aware of those that are at disadvantage at any time.